Good afternoon, ladies and gentlemen. First and foremost, like to thank the APASL President, Professor Sheena, and the APASL Kyoto Organizing Committee for this wonderful invitation. It's my great honor and privilege to be with my mentor, Professor Jacob George, Professor Islam, and the rest of the panelists and speakers, Professor Tawandi, Professor Ho, and Professor Kawaguchi. So I have nothing to disclose for my presentation. So in my talk today, we will delve into the historical evolution of the terminology, understanding why these changes occurred, and we'll examine the changes in the diagnostic criteria that accompany the evolution and how these changes influence disease identification, and will analyze the clinical implications of transitioning from NAFLD to MAFLD and MASLD, focusing on how it impacts the understanding and management of fatty liver disease by emphasizing accurate diagnosis, improving patient care, and achieving better outcomes. So let's look into the evolution of the nomenclature of liver disease over time. In 1836, Addison described a fatty degeneration of the liver in patients with excessive alcohol consumption. In 1970s, hepatologists reported a similar pathology in patients with obesity and related disorders. And in 1980, Ludwig first used the term non-alcoholic hepatitis. In 2022, Professor Islam, Professor George, and other colleagues proposed to rename the NAFLD as metabolic dysfunction associated fatty liver disease, and MAFLD has garnered recognition from 40 different organizations worldwide. In 2023, the ASLD, EASL, and the ALE published the nomenclature of the definition of metabolic dysfunction associated steatotic liver disease. So we all know NAFLD is defined by the evidence of hepatic steatosis with no causes for secondary hepatic accumulation. So this is a diagnosis of exclusion. It's associated with obesity, diabetes, and dyslipidemia. So, in the past decades, the experts in the field have been advocating for the change of the name NAFLD. So, there's problem with the terminology of NAFLD because the non-alcoholic terminology stigmatizes the disease. There's a need to distance from the disease. It does not capture the heterogeneity of the patient population and what is really the safe limit of alcohol, and it does not define the individual's phenotype with enough precision, and the NAFLD diagnosis is based on exclusion, and there's a need to diagnose using positive criteria, and also we need to remember NAFLD can coexist with other liver disease, so there's a synergistic effect on the outcomes, and there's a lack of patient awareness, public response, and funding for NAFLD. So in 2022, a consensus group of international experts led by Professor Islam and Professor George convened for the APASL guidelines introducing the new nomenclature metabolic dysfunction associated fatty liver disease. So there's a positive diagnosis recognizing the close relationship with the metabolic disorders. There's elimination of the steatohepatitis and allowance of more liberal alcohol use. So MAFLD is defined as the presence of hepatic steatosis in three subset of patients, namely overweight or obesity, patients with type 2 diabetes, and patients with lean or normal weight with the presence of two or more metabolic risk factors. So let's look into the similarities and differences of NAFLD and MAFLD. So both conditions require hepatic steatosis. The main difference lies with MAFLD, there's a requirement of the metabolic dysfunction. A combination can combine with other liver disease and also independent from alcohol intake, and there's no requirement for liver biopsy. And for NAFLD, you require liver biopsy for the diagnosis of NASH. So there's a lot of arguments in renaming NAFLD to MAFLD because of the validity of the process. It may be confusing and jeopardize the impact on the disease awareness. And also, we have to remember there's an impact of the alcohol and the lack of clarity on metabolic dysfunction, as other liver diseases, as Wilson's disease, are also metabolic in nature, and the adaptability to the emergence of the different disease phenotypes and the issues on drug and biomarker development. Is MAFLD different from NAFLD? So this is a large cohort study wherein the MAFLD and NAFLD shows excellent concordance. There's no major differences in the clinical characteristics except for components like alcohol use in patients with MAFLD. So on follow-up, there's no difference in cumulative all-cause and cause-specific mortality, and insulin resistance predicts the liver mortality in patients with NAFLD, and alcohol-associated liver disease predicts mortality in patients with MAFLD. So there's a robust evidence for the validity and superiority of MAFLD versus NAFLD. There's a lot of studies looking at the superiority of MAFLD versus NAFLD, allowing disease stratification, increased disease awareness, reduces the stigma, and identify cases irrespective of the other disease, allowing for identification of coexisting disease, and potentially accelerates drug development applicable across all health systems and improve identification of the severe hepatic and extrahepatic disease. Last year, the metabolic associated steatotic liver disease was introduced. So under the umbrella of the steatotic liver disease, if the patient meet one out of the 5 cardiometabolic criteria with no other causes of steatosis, this is classified under metabolic dysfunction associated steatotic liver disease. And if there's other causes or coexisting etiology, is termed as MAFLD for patients with alcohol intake and other combination etiology. If the patient does not meet the cardiometabolic criteria, they will be classified either cryptogenic SLD or other specific etiology in the SLD. So in particular, they introduced the new concept of MAFLD. These are patients with MASLD increased alcohol intake. So this is a continuum from the MASLD predominant and the ALD predominant. So it lies on the amount of alcohol intake of the patient. It's 210 for female and 280 for male for patients with MAFLD. So more than that, the patient is ALD predominant. So looking at the NAFLD and MASLD, are they the same disease? So they're very similar in the large NHAIDS database. The mortality is slightly higher in patients with MASLD. But the problem is MASLD may miss some cases, particularly in the primary care setting. And for vast majority of patients, the nomenclature does not change the evidence generated. So I'd like to share with you a study from our institution. This is a research work on one of my fellows in training. So he will present this on March 28th, Dr. Lawrence Torwell. So we look at the comparative analysis of clinical demographic profile and outcomes in NAFLD, MAFLD, and MASLD. So around 200 patients were included in this study. So there's no difference between the clinical demographic profiles of the subgroups studied. So in this particular study, 50% met the criteria of NAFLD, MAFLD, and MASLD, and around 30% of individuals met the MAFLD criteria alone. So if we look at the outcomes in this particular paper, around 23% of the patient developed cirrhosis over time, 100% is diagnosed with MAFLD, followed by MASLD and NAFLD. So in this particular study, the MAFLD better identifies patient with higher risk for cirrhosis than NAFLD and MASLD. So the MAFLD criteria does not only alert the population to a greater risk of cirrhosis, but also identify a group who may have more risk for adverse hepatic outcomes due to coexisting hepatic illness such as hepatitis B and alcohol. So in another study, they look at MAFLD and excessive consumption as independent risk factors for mortality. So the key findings of this study showed that MAFLD and excessive alcohol increased mortality risks. MAFLD mortality risk was not modified by alcohol. It was consistent for the different alcohol cutoffs, and MAFLD seems important regardless of the alcohol intake. So in summary, The shift from NAFLD to MAFLD and MASLD is a significant conceptual change in our comprehension of fatty liver disease. So this evolution sparks the ongoing debate around NAFLD, MAFLD, and MASLD, and serving as a reminder of the dynamic nature of the medical terminology. The call is clear. We need to unify the new terminologies, and MAFLD, MASLD underscores the strong association between the metabolic dysfunction and the fatty liver disease, emphasizing the need to address the underlying metabolic risk factors. So, steering our comprehension to a more holistic understanding of these conditions. So there's a lack of granularity and specificity of the MASLD criteria, including in the general population and the post-transplant. MAFLD is superior in identifying significant fibrosis and all-cause mortality compared to MASLD. So MAFLD is the only definition right now, maintain the right balance between the sensitivity and specificity. Thank you very much for your attention.
Thank you so much, Professor Q, for this outstanding talk. So we will hold for the question for the end of the session. So our next speaker is Professor Kawaguchi from Japan, who doesn't need much of introduction. Unfortunately, he couldn't join us in person today, but he will be joining us online. He will be talking on the etiology and usefulness of MAFLD in the Asia-Pacific region. Professor Kawaguchi.
Thank you for your kind introduction, Professor George and Aslam. And first, I express my sincere thanks to President Senior and organizing committee for giving me an opportunity to present my work in the session today. And I deeply apologize for making my presentation on the web. And let me share my slide first. The title of my presentation is Etiology and Usefulness of MAFLD in the Asian Pacific region. Here is my COI. This is the prevalence of MAFLD in Japan. We investigated the prevalence of MAFLD from 2014 to 2018 using the 13 health centers in Japan. The prevalence is 25.8% in general population. And of these, diabetes was seen in 40%, hypertension was 31%, and dyslipidemia was 48% of patients with MAFLD. So in other words, there is a high prevalence of metabolic dysfunction in patients with MAFLD in Japan. In 2020, the international expert panel led by Professor Aslam and Jacob George and proposed a new definition of fatty liver called MAFLD. That is a fatty liver with metabolic dysfunction. MAFLD can be diagnosed if the patient has a steatosis with obesity or type 2 diabetes mellitus, or even in patients with a lean normal weight. MAFLD can be diagnosed when they have at least 2 metabolic risk abnormalities. Today, I'd like to introduce some advantages of MAFLD, and then later on, I'll briefly introduce our data for the treatment for diabetic MAFLD. One of the advantages of MAFLD is inclusion criteria. MAFLD is diagnosed based on exclusion criteria by alcoholic intake and viral hepatitis, as well as other etiology of chronic liver diseases. However, MAFLD can be diagnosed with the inclusion criteria with a risk factor for the events. So MAFLD is thought to be captured on high-risk patient for various events. We examined the diagnostic ability of MAFLD who identified a patient with significant hepatic fibrosis. We used the data for health check exams by using a shell wave elastography. The diagnostic ability of MAFLD is sensitivity is 93.9%, and negative predictive value is 95.5%, which is approximately 20% of higher screening rate for the significant hepatic fibrosis. So with this data, we can conclude that MAFLD identified the patient with significant hepatic fibrosis better than NAFLD. Another advantage of MAFLD is that can examine the interaction with other liver disease because it's independent etiology for liver disease. For instance, we can examine the interaction with an HBV or HCV or alcohol or a combination of these etiologies for development of cirrhosis and HCC. Here, I'd like to introduce our data for the impact of MAFLD on SVR HCC patients. We examined the impact of MAFLD on the incidence of HCC after the HCV eradication. You can see the data here. After eradication of HCV, some patients developed HCC even though the eradication of HCV. At this point, and the incidence of HCC at 60 months is 25.8% if patient had MAFLD, which is extremely equal to the rate of patient with AFP greater than 7 nanogram per milliliter. That is 23.9%. So the data can tell that the impact of MAFLD on the HCC in patients with eradication of HCV virus. The third, the advantage of MAFLD is, I like to say that the field of HCC, because the etiology of HCC used to be classified HBV-related or HCV-related or non-viral related HCC. However, the prevalence of non-B, non-C, or non-viral HCC is gradually increasing and getting to a major etiology of HCC. So we propose that the MAFLD-related HCC or alcoholic-related HCC or autoimmune-related HCC can be set for an independent etiology for HCC. The next, I'd like to introduce our data for the impact of MAFLD on HCC treatments. We investigated the effects of MAFLD on lenvatinib treatment in patients with non-viral HCC. Here we can find is kind of interesting because we expected first MAFLD-related HCC has a poor prognosis, but the result was opposite. Overall survival is much better than the MAFLD-related HCC compared to non-MAFLD patients. We do not know the exact reason why we have so unexpected result, but the patient with MAFLD tends to have a higher BMI, which related to the better compliance of the anti-cancer medication. So one of the possibility is relatively better nutritional status in patients with MAFLD. The first, MAFLD may have a significant impact on extrahepatic diseases. Since patient with MAFLD has an adipocyte abnormalities and an insulin resistance, as well as a systemic inflammations, these pathological situations cause the extrahepatic diseases. Then we examine the impact of MAFLD on the progression of ASCVD. Something like a heart attack. You can see here is the red line shows a MAFLD and a blue line shows a NAFLD. the cumulative incidence rate of worsening of the Framingham risk score, which is a risk of ASCVD, and is much higher than the MAFLD patients, than the NAFLD patients. So NAFLD better predicts the progression of ASCVD risk than patients with NAFLD. Another interesting thing is that we can find is that MAFLD is related to the Helicobacter pylori negative gastric cancer. Now we can often see the patient with gastric cancer with no infection of Helicobacter pylori. And then we investigated the impact of MAFLD on that disease. And what we found is in the decision tree analysis, the most impacted factor was a MAFLD, and then later the aging. So to manage the patient with MAFLD, we have to take care of the gastric cancer as well. We also examined the impact of MAFLD on a colorectal adenoma, and what we found is non-obese MAFLD has a higher incidence of the colorectal cancer than the obese or diabetic MAFLD. And this is also an expected result for us, but maybe one would think that the reason is in non-obese MAFLD can be diagnosed with at least 2 metabolic dysfunctions, not only one. So the number of metabolic dysfunction may be one of the reasons for the higher incidence of colorectal adenoma in non-obese MAFLD. For the summary of the first part, MAFLD, I think, enhances clinical practice for the liver disease in the Asian Pacific region, and especially on the non-obese fatty liver and viral hepatitis or alcoholic liver disease, or non-B, non-CHCC, in addition, sarcopenia and disease awareness. Then I'd like to introduce briefly our data for the treatment of diabetic MAFLD. This is the Japanese guideline for the evidence-based clinical practice for NAFLD and NASH 2020. And there is a clinical question that is SGLT2 inhibitor effective for NAFLD or NASH? The committee has a 100% of agreement, but the evidence level is C and a strength in 2. So that's because a lack of sufficient evidence, especially there is no meta-analysis investigating the beneficial effects of SGLT2 inhibitor on MAFLD. So we performed a full meta-analysis using 5 phase 3 clinical trials in Japan. The number of the patient was 1,310, and we excluded the 23 diseases which may affect fatty liver and fibrosis, and the remaining 634 patients were enrolled in the study. And then glyphosate is an SGLT2 inhibitor in Japan, and the group is 302, and a placebo group is 191. Here is a primary outcome, and we can see the significant reduction of the fatty liver index and the NAFLD liver fat score, as well as the hepatic steatosis index at 12 weeks and 24 weeks. So glyphosate, SGLT2 inhibitors significantly improved various indexes for hepatic steatosis compared to placebo. Another primary outcome is the FIB4 and the fibrosis score. In patients with the FIB4 index greater than 1.3, we can see a reduction in a fibrosis score and APRI at 24 weeks after the treatment. Similar findings were seen in patients with ALT greater than 3 units per liter. Again, fibrosis score and APRI significantly decreased after 24 weeks treatments. So these 2 fibrosis indexes were significantly improved by the treatment of SGLT2 inhibitor. So I would say SGLT2 inhibitor, one of the treatment option for the diabetic patient with MAFLD, especially and the with the hepatic fibrosis. So today, my talk is about the advantage of MAFLD especially in Asian Pacific region, and then treatment for diabetic medication. Thanks for your time.
Thank you very much, Takumi, for that great talk. I hope you'll actually stay for the discussion, which is going to be at the end of the session.
Sure.
So we are running ahead of time, so that's great. We'll have more time for discussion, so please prepare your questions. The last talk in this session is by Professor Jinlin Hu, and he's going to be talking about a MAP-based score system to evaluate fibrosis stage and risk of HCC in liver diseases and various etiologies, including MAFLD. Thank you, Jinlin.
Thank you, George. Mr. Chairman, ladies and gentlemen, my name is Jinlin He from Guangzhou, China. I will, switch to a different topic using two examples by using digital medicine. First, I use this kind of approach for prevention mother-to-child transmission of HBV infection. Currently, main work on how to use web-based MAP score system to evaluate liver disease severity, including cirrhosis and HCC. So I would like to start my talk first to have a look back how to block mother-to-child transmission of HBV infection. As all you know, in our region is a very serious public health problem. We started our program since 10 years ago. We called the name is a shared program because in China, there are approximately about 23 billion women of reproductive age are surface antigen positive. Recently, this number is declined annually, resulting in around 250,000 more, 250,000 cases annually, new HBV infection in baby. So how did we implement a shared program? First step, we identify evidence-based policies and invention. Then we do some pilot study to further adapting the policy and intervention. And then we further evaluating the implementation of a policy of intervention in large scales. Finally, scaling up policy or intervention in area. Government designated this area as a very important area for eliminating viral hepatitis mother-to-child transmission. As all you know, recent year, prevalence of surface antigen in China is gradually declined, particularly in young age, around 0.32% in babies less than 5 years old. China used to be very high prevalence area 20 years ago for HB infection. This is due to successful vaccination program. You will see coverage rate for HBV vaccine and HB more recently over 95%. One of the key factors recently, a lot of guidelines, APASO guideline, AIRS guideline, and the Chinese guideline for HBV infection, they introduced the additional information for mothers with a high HBV viral load in third trimester with additional antivirals. Currently, predominant they use in tenofovir. So we will have a look at our program for first stage. Stage 1 is a pilot study. Voluntarily surface antigen mother across 10 sites nationwide with thousands of baby mothers with surface antigen positive in stage 2 from 178 hospitals across China, linked doctors linked by APP with patients with in different hospitals. Stage 3 in Bao'an district of Shenzhen. This Shenzhen city is next to Hong Kong. Is very famous, it's for development economy, but also a lot of mobilized the people from other cities to this city. And then we set up a algorithm, 2 key steps for preventing mother-to-child transmission. As I mentioned to you, screen, management of pregnancy, delivery management, discontinuation antivirus, third trimester with additional antivirus for high viral load mothers. We link our patients and doctors from from hepatologists, ID doctors, pediatrics, etc. together. Over 1,500 medical staff who join this program. So we will have a look at the effectiveness of implementation from this so-called shared project. First stage, you will see overall rate of mother-to-child transmission of HBV infection is 0.9%. Second stage is 0.23, exactly same in third stage 0.23, much more lower than WHO set up a target by 2030, 2%, less than 2% mother-to-child transmission. One example is the Bao'an district in this area next to Hong Kong. We introduced new measures to this area. This area with it is a good representativeness with a surface antigen prevalence rate of over 80% among pregnant women. We set up a one-step service. You will see integrate our service related with mother-to-child transmission of HBV infection. WHO, in his official website and Sino microblog reported this program. Hope to, have more awareness, not just in patients and doctors, as well as to health authority. This work just published in Nature Medicine February issue. This is I think the example we learn a lot from this. We call the digital medicine approach for implementation to block mother-to-child transmission. Now we're trying to apply this kind of approach to using a score system to manage of our patient with liver disease. This score system we call the name is a map for HCC risk stratification. This score system could combine with biomarker currently used in clinical practice, something like alpha-fetoprotein, DCP, or more advanced technology, cfDNA test. More recently, we're also using a mapper for liver fibrosis and cirrhosis diagnosis. The real life practice is not so easy to do. It's easy to say, difficult to work. MAFLD is, I think, currently the most common cause of chronic liver disease, as a lot of speakers already mentioned. Currently, there are available, system for accurately evaluate MAFLD-related cirrhosis, MAFLD-related occurrence of HCC. You will see only a few HCC risk models have been developed for MAFLD patient in clinical practice. We do not realize MAFLD patient will have high incidence of HCC. Partially model just targeting cirrhosis or non-cirrhosis MAFLD patient. Most of the models they use in clinical parameters such as age, sex, etiology, palate. Some of them they add genetic factors such as PNPLA3 SNP, TM6SF4, etc. Others they using combine alpha-fetoprotein, L3, alpha-fetoprotein, DCP, etc. However, there are limitations for existing HCC predicting models. Most of models introduced infrequently used or even expensive variables into the model. Thus, it is difficult to promote in our region, particularly in some of Asia Pacific area with developing economics. The other limitations are only performed satisfactorily among populations with specific region set up in either European or American or Asia area, not widely validated and applied. So we hope to set up an updated HCC risk score, which is simple use, pan-ethnic, pan-etiology is likely needed. So we call this score system MAP score. It is an objective, simple, reliable risk score based on 5 common parameters: age, sex, platelet, album, total bilirubin, which could accurately predict HCC occurrence regardless of etiology and ethnicity. We are lucky to get support over 900 more sites globally, collect the data together. We follow up a large cohort of patients over 5 years. Most of them already 10 years. We using this MAP score system to further stratify our patient to as a high risk patient with annually incidence of occurrence of HCC high to 4%. For low risk population account for 44%, is less than 0.2% annually developed HCC. First stage, we develop this model in HBV cohort. Is a study initially sponsored by BMS, is a global trials. A lot of you sitting here might be one of key investigators. Professor Tawana, I know there is a patient for this cohort. Then we validated from 11 different cohort, HBV, HCV cohort, also not big number mastered cohort of patient from Japanese group. We constructed based on HBV cohort. This MAP score also is good performance in NASH cohort. C index value was 0.85. So still there are limitations for MAP cohort. We hope to further improve this cohort. We combine, it's by new methodology, combine MAP score, dynamic changes of MAP score, and changes alpha protein. We create a MAP2 score. And also, based on a MAP2 score, we add on CFDN for hope to further improve the diagnosis value. You will see from this result, among cirrhotic patient, MAP2, MAP2 plus score gradually show increase AUC and are superior to other current available HCC score. Based on our result, we suggest we use so-called stepwise approach for clinical screen and monitor occurrence of HCC. At baseline, using very simple clinical parameters, age, sex, bilirubin, albin plate. A MAP score then separate patient to medium to high risk of HCC occurrence, low risk of group. Then we add dynamic changes of MAP and alpha protein. We call the MAP2 further distinguish our patients to very high risk group. Annually, HCC incidence is 3.7%. And then we add on CFDA data. We will further enrich the high risk of HCC patient to up to annually 12.5%. Currently, we are doing screen program. Hope to use this MAP score in web-based approach to serve more people, particularly for community center. And I will use 2 slides to have a very, very brief look. A MAP score is capable of evaluating liver cirrhosis and fibrosis. We get a lot of investigators support, combine over 946 liver biopsy confirmed mastered patient from China and the United States. We using a MAP to hope to have some important messages for diagnosing cirrhosis and advanced fibrosis. we find this system is comparable to FB4, superior to that of APRI. So a MAP score could avoid more patients from unnecessary liver biopsy in future. We hope to do some more prospective study in our region, combined with the new technology such as machine learning, AI, etc. Ladies and gentlemen, here is my conclusion for a MAP score. Is a useful tool for improve early HCC detection. Individualize the HCC screen and diagnosis strategy by using a MAP score and accurate biomarkers is cost effectiveness to improve the early diagnosis of HCC. Also, a MAP score might be useful for diagnosis of liver cirrhosis and advanced fibrosis. Thank you for your attention.
Thank you so much, Professor.
Hope to see all you in Beijing, Apostle 2025. Thank you.
Thanks. So please, may I call all the speaker and discussant to the stage so we start the discussion?
And can we have the online speaker, Professor Kawaguchi, also online?
Yeah, I'm online.
Okay.
So yeah, any question?
Excellent talk by all speakers. Can you tell us the screening protocol of HCC? Because in MAFLD, because in hepatitis we do it 6 to 12 months, but in hepatitis, like in our country, like Pakistan, I'm from Pakistan, so there's 5% of the population. But when we talk about MAFLD, it's 30% because 30% has diabetes. Pakistan is #1 country in diabetes and among the top 10 countries in obesity. So 30% you will be screening every 6 months or 1 year. That would be huge economic burden for a developing country. So how to screen HCC and fibrosis? Do we need to do it every year, every 2 years? So what's the protocol? Anyone can answer you.
Thank you for your question. Currently, we are doing this kind of program. We hope to, in future, set up a web-based evaluation system, not just in China, also in our Asia Pacific region. You can input your clinical parameter in this system, then evaluate your patients. This first. Second, you mentioned about diabetes. One of professor from Shanghai, they further evaluated our score system. They add diabetes as a risk factor in their subgroup of patient with additional value for predict HCC occurrence. Thank you.
Thank you.
I think just another comment about that. We actually went through a detailed systematic review in Australia looking at HCC prediction tools and looking at cost effectiveness. One of the problems was cost effective studies. You really need to do it based on the cost of an ultrasound or whatever test you have in your own country. So it may not be completely applicable. I think everyone agrees that HCC screening for cirrhotics is required. I think what we need is data on the risk groups that you're talking about. 30% diabetes prevalence is incredibly high. whether if you've got diabetes and no cirrhosis, what is your risk of HCC and what is your cost utility in your own country? That is something that would be, primed for research. But currently, for MAFLD, it's cirrhotics, because we know that on average, liver cancer doubles every 3 months on average. But we don't know the precise answer, I think, to your question.
So Ajay Duseja from India. Very nice talks and very nice session. My comment and question is for Dr. Kua. Without getting into the which nomenclature is better or best, probably there's an evolution which is happening, and I think there were limitations with NAFLD, there are limitations with MAFLD and MESL, all three, and as I said, there's always a room for improvement. My comment is that when this change happened, we actually put in our departmental data of more than 1,000 patients and tried to see that whether these are fitting into the NAFLD patients, fitting into MAFLD and MASL. So since MASL also had that central obesity into being, and the MAFLD had that CRP and HOMA, which we normally don't do very frequently. So we said, and we published this in JHAP, and we said that yes, probably MESL could be better. But now what we have done is we have a huge consortium in India called Indian Consortium on MESL-D, ICOM-D, and we analyzed our data on more than 8,000 patients. And there what we found was that around 87% of our patients are, which we initially included as NAFLD, were fitting into MESL. So we were left with those 13%, which were not fitting into, MESL definition. So when we went back and saw everything, so metabolic dysfunction was kind of absent in all those 13%. So which means that we do have steatosis in Asia Pacific, and these are specifically those lean patients, those who are normal BMI, normal waist circumference, but still have steatosis. Now you can't call them MESL-D or MAFLD, but they were steatotic liver disease. So by the MESL definition, they will get into what they call the cryptogenic steatotic liver disease. But we don't feel they are cryptogenic. We feel that today they may not have a metabolic dysfunction, but tomorrow they are going to have it. And this is, we know by the natural history of steatotic liver disease, that many of them will develop metabolic dysfunction later in the course. So what are your thoughts and comments, and how do we sort this, so-called, actually, which is NAFLD, but we are now forced to call them as cryptogenic. So what are your thoughts on this, Taman?
Okay. So with regards to the nomenclature, MAFLD, MASLD, I think they are talking the same language except for some, criteria. Like for the MASLD, they look into 1 out of 5 cardiometabolic factors. So that includes hypertriglyceridemia, the low HDL, and also hypertension. So I think the problem lies also with the inclusion criteria and also the inclusivity of the alcohol use. They conceptualize in a different condition as MET-ALD, and it has been shown that in actual clinical practice, most patients do underreport their alcohol intake, and then there's some recall bias, and they don't, you know, they cannot quantify the alcohol intake. So in your question with regards to these lean patients who did not meet the MAFLD muscle criteria, I think we have to look into that. So that's a very good data to study on, particularly in our Asia Pacific region.
And I just like, if I can add one comment here on this one. So we know that like for a disease like fatty liver disease, whatever you call it, which affect almost like 1/3 of the population. Okay, and before even any discussion about the nomenclature, when you look for all of the guidelines, all of this kind of algorithms, which you can find it in all guidelines, the American, European, Asian, the aim was to identify the patient or at high risk that they require a referral to tertiary hospital, and to select them from those who are unlikely to develop any complication on the short term. So maybe I'll ask you one thing here, just to enrich the discussion. Is our aim here is to give the label of disease to as many patients, as many individuals as possible, or to identify those actually at high risk of disease? So we now have evidence which came from India, came from Europe, came from America, saying that almost 90% of the global population, the normal population, are meeting the criteria of MASLD. So is the point now is to just increase those who will take the label of a disease, even if they are not going to develop any events, or to identify those at high risk. That's one thing. And the second point, just I want to mention why we are insisting that these lean patients, who they don't have any metabolic risk factor, they are actually having metabolic dysfunction. They might, as Professor Q mentioned, they might have an alternative cause. And lastly, what do we know at the moment about their natural history? There is a study from Professor Kawaguchi. He published, I think 2 years ago, he looked some sort of meta-analysis for this group of patients, and we know that they don't have any difference from the general population. So I think just by evidence, as Professor Kuhn mentioned, that the MAFLD definition strikes the right balance between not missing any patient, but identifying those at high risk.
No, I absolutely agree with you, your comments you make. But, what I'm trying to say is, what did you say about you said there could be an alternate etiology. That's number one. Yes, that's possible. But then having excluded all the, known etiologies, and still, as I said, they were fitting into those cryptogenic. But then having said that, why I'm saying that they could still be metabolic dysfunction, because we don't know whether just looking at the BMI, just looking at the waist circumference, are we really ruling out, the real, pathogenic thing which could be happening in them? That's the number one point.
Yeah.
And I think the second issue, which
About the lack of
yeah, so I think the second issue is very important, that I'm very happy, you guys have done a wonderful job. And now the message, that the good thing is that even though we're talking about change in definition and terminology, but everybody is sticking to that the risk stratification algorithms remain the same, which is very, very good, important point you're saying, that we have to identify whatever you call them at risk patients, and then whether you want to manage them at a primary care level or want to send them to secondary or tertiary care level is very, very important. And that is not changing even with the change in terminology. I think that's very, very important.
So we agree that the most important is identifying at high risk, and MAFLD do this better than MASLD.
I think the only other point I'd like to mention is this concept. Everyone agrees, and this is a paper we published back in 2000, the underlying pathophysiology is insulin resistance. And to insulin resistance, what gets added with our understanding in the last 10 years is metabolic inflammation. And all the criteria we use, whichever definition, whether it's hypertension, diabetes, all of that are just surrogates for the inflammation part. And that's where I think looking for metabolic inflammation with HSCRP, the cardiologists use it. We know that people with no metabolic risk factors like hypertension, diabetes, atherogenic dyslipidemia, if they have a high HSCRP, they have an increased risk of myocardial infarction, despite the absence of traditional risk factors. So you need something that also looks at metabolic inflammation and also insulin resistance. And I think that's the best framework to be able to actually look at your patient at an individual level. Interested in any other comments from the panel?
Since the term MAFLD just recently implemented, do you foresee the convergence or divergence of it? It seems that it's not exactly the same, but it's pretty similar. But in the future, after implementations of these two terms in parallel, and Professor Kawaguchi just mentioned regarding the MAFLD associated, and not only for Professor Kawaguchi, but many studies to look at the MAFLD associated more metabolic complications on the long term. So in both of you are among the forefront of the others and researcher in this field. Do you foresee the outlook of these two terms in the next few years?
Look, I think everything in science is evolving. My only plea is that the evolution should be based on evidence. Scientific truth doesn't change. So I think as long as whatever the eventual outcome, it should be based on science, not with white-haired men like me sitting there and saying, this is what it's going to be. It's got to be based on scientific evidence, and the evidence will actually lead us to the truth. Professor Minglong, do you want to make any comments from Taiwan?
Okay, I think it's quite interesting for the two new nomenclature. So there are 2 points. The first point is the term statosis and fatty. I think it's just maybe it's political, not based on science, so it's okay, based on a different opinion. But the third point is that both of the nomenclature that focusing on the metabolic dysfunction, I think it's okay. It just only depends on the criteria of what is a metabolic dysfunction. The MAFLD use obesity, diabetes, and another 7 criteria. Is quite exclusive. But the MAFLD that use 5 criteria that used to be the criteria of metabolic syndrome. I think it's quite the same, but I think it's more simple. It's simpler because only the 5 criteria is much easier for the general practice. So that's the difference. So I think we have to work on the what is the best definition for metabolic dysfunction. I think we need more and more study and a longer follow-up duration to explore what is the key points of the metabolic of the components for the metabolic dysfunction.
Professor Wah Keong, we've heard from Japan, from Philippines, from China, from Taiwan. What about some comments from Malaysia?
Well, I agree with the discussion that has been going on. And one good thing is that regardless of MAFLD or MSLD, there's now a recognition of the underlying cause of the disease, that is metabolic dysfunction. But perhaps what is difficult is to pinpoint at what kind of level that we want the sensitivity of making that diagnosis. A bit like how we diagnose diabetes. We know that for diabetes, it's a whole spectrum of, for example, HbA1c. Why is it that we use 7% to diagnose diabetes? Why not 6.9? So I suppose if you were to use a more strict criteria to define metabolic dysfunction, and the more relaxed criteria like what we see in MSLD, it's just a matter of being more sensitive or less sensitive, more relaxed or tighter in that sense. And of course, in diabetes, we have a condition called pre-diabetes. So whether if you were to use the MAFLD criteria to define the disease, and the MASLD criteria would be somebody who has less severe form of the disease. But we also have to remember that there's a significant proportion of patients who do not have steatosis at all, but yet they fulfill the criteria for MSLD for the metabolic dysfunction. So in that sense, maybe the MSLD criteria is indeed a bit too relaxed.
Professor Alam, so what do you think?
Thank you very much for inviting me to comment on this. Actually, MAFLD was published in 2020, And before that, we all agreed that NFLD should be redefined by new nomenclature, and MFLD was the best fitted. After that, the MASLD was proposed, and that at that time, the main thing was the MASLD, that the steatotic liver disease. They think that it is a new one. If we think that, if we tell any patient that you are suffering from steatotic liver disease, the next question this patient is asking us, so what is the steatotic? Then it is the fatty liver. So in this regard, we think that MFLD is best fitted definition to include the patient, and also defining the patient who are in the risk of developing different complication. Thank you all.
I think we've got the president of ALE here. We might get a perspective just to be inclusive and get every opinion.
Okay, well, the MAFLD is very inclusion, and the patient is no stigmatizante and include a patient with no alcoholic. It's different, the alcoholic, but a no stigmatizante only.
Thank you. Any other comments from the panel or the audience? I know that this is the only thing stopping you from getting to afternoon tea. So
I just want to go back to the AMAP score. Thank you for inventing the AMAP score. But my understanding is the AMAP score is going to use this is a tool to stratify the patient whether they have the risk of HCC high or low, right? It's not replacing the screening protocol for detecting HCC, right? And in your low AMAP score model, I saw that the incidence of HCC is still about 0.9. 0.9 is still higher than the threshold that we start screening. So how do you manage the patients with low AMAP score?
Thank you. You are absolutely right. Because currently most of guidelines suggest that annually twice for screen HCC by Chinese guideline by alpha-fetoprotein, ultrasound together. In future, we hope we will for very low risk of population annually one times for screen will be more cost effectiveness. Also, currently we next we combine alpha-fetoprotein, DCP together with modified something like a map to further improve this score system, particularly in community center. Currently, we hope to gradually incorporate this system because in China, a lot of community centers they do medical checkup for their citizens, but not use their data for do analysis. Thank you.
I think the only point to actually mention in regard to that, you mentioned the point, the 0.9 incidence of HCC, and all of that dogma started because the AASLD had published something on 1.5 based on US costs for ultrasound, which are about 3 to 5 times higher than any other country. So I think the threshold that you use for screening or not screening really should be based on data from your own country with the costs in your own country and whatever the government decides to fund. Is it 50,000 US dollars? Is it 10,000 Thai baht or 100,000 Thai baht? Until you actually do that, I think everyone's thought of 1.5% as holy grail. this is the threshold you need to meet for it to be cost effective. That's cost effectiveness in the US.
Yes, but actually the cost effective in the US, that was the cost that Professor Maurice Sherman used more than 20 years ago. But nowadays, the GDP increases. I think $50,000 maybe is not the true figures for using at a base for cost effective.
Exactly.
And just finish up. Would you please make an application for us to use the AMAP score for easily to calculate, because we now using the web-based calculation. It's not easy for people for young generation. They would like to have the application.
Thank you. I think in future we will hope to do so, particularly incorporated some biomarkers for HCC, such as GAD, GAD, GALID, etc. Thank you.
Thanks. So, any other comments or questions?
Yes.
Yeah.
Yeah,
Yes.
just one question for Professor Professor G. For the AMAP tool, you use the AMAP alpha beta protein and cfDNA. I think the alpha AMAP is quite similar to for the stratification of risk based on the disease severity, such as fibrosis, quite similar. But the cell-free DNA is quite similar to the nature or character of tumor itself. So, are you going to try to use a different algorithm or sequential algorithm for patient with high risk by AMAP, then followed by the cfDNA alone, because it may be more focused on the early detection. The AMAP may be focused on the screening risking.
Thank you, Minglu Professor. I think currently CFD is still not yet approved in real clinical practice, only for research. Also, different company in either China or outside China develop a different platform for test cfDNA. But now still there is a problem for routine clinical practice. Our method just for predict risk, not for diagnosis of HCC. Currently, we are going together with Professor Dennis Lau from Hong Kong. He is doing some screen program, hope to diagnosis, not just predict risk by using liquid biopsy methodology. Thank you.
Thanks. Yes.
We are seeing a lot of patients in pediatric age group in MAFLD, basically. So do you think that in pediatric age group, this definition will hold true, or we need to modify it, because all of the factors will not be possible sometimes in pediatrics? So this definition also holds for the pediatric age group, or we need to modify for the MAFLD?
So just in terms of the pediatric age group for you're talking about AMAP for pediatric patients?
Yeah, because sometimes the definition does not basically apply in the pediatric. Sometimes they don't have, the high triglycerides and diabetes, but they are obese, so they are pre-MAFLD or sort of a thing. So do we still apply this definition to the pediatric age group, 8 years, 10 years of age?
Thank you for your comments and suggestion. We have no any data about this subgroup of patients. Thank you.
There's a paper today morning in JPGN, which actually is on the pediatric steatotic liver disease, and this is by a multi-society statement endorsement of the nomenclature and characteristics. Maybe I can forward it to you. So this has a lot of, I think, 13, 14 societies which are looking for this.
And
there's a paper today morning on this. Yeah.
We have a research study will be online in few days from now. We compared the pediatric MAFLD and MASLD criteria, and I think even if we agree on the adult criteria, the MASLD criteria and pediatric needs a significant modification. First of all, they don't apply age specific. It's all coming as the same. So, for example, the one standard deviation that they use to define the overweight for those who are less than 6 years, that's normal weight actually. So this will be online in few days from now. I think even if we agree on the adult criteria for MASLD, the pediatric one needs a significant modification.
If we think that inflammation is the underlying devil, so if assuming the cost is not a problem, which marker would you use? So I think it depends what you're trying to diagnose. If you're trying to diagnose metabolic systemic inflammation, the best marker we have is hsCRP. Does that actually translate to liver histology showing steatohepatitis, which only 50% of 5 pathologists in the world can agree on? That becomes a problem. So I think first you have to decide who you want to treat. And as a general principle, the earlier in a disease you treat, the better it is. So you could make a good argument, say, to start treating people when they become obese, when they become diabetic. Or you could wait just for cost considerations, looking at F3, F4. So it becomes very, very muddy in terms of diagnosing. But if you want to diagnose metabolic inflammation systemic, doesn't tell you much about the liver. We published a study on hsCRP a long time ago to predict steatohepatitis, metabolic steatohepatitis, and it was only 60% accurate. But is that because of biopsy variability? I think everyone accepts that they have got metabolic inflammation. Either that or we're not measuring the right sort of marker for inflammation and picking up the patients most at risk. Yeah. I think the problem with finding out, apart from hsCRP, every other marker for metabolic inflammation can rapidly change. So, you change your diet, you do some exercise, you eat vegetables, whatever. And it's very, very different from hepatitis C or hepatitis B. It's a single blood test and it's easy to do. Metabolic inflammation changes with time, changes between years, it's different between sexes. Depends on the quality of the diet, apart from things like calories and exercise. Even sedentary activity becomes very, very important. When you try and define metabolic inflammation, so much harder to do. We might need AI for that. Thank you.
Yeah. So, any more question or comment? So if not, so by this we can wrap the session. Thank you so much for all the speakers and the panelists for this great discussion. Thank you for coming.
Thank you very much, speakers, discussants, and moderators. Now we will have a coffee break. Coffee is served in front of the main hall. The next